Okay. Good morning, team. Thank you for all meeting today.
Good morning.
Good morning. Why don't we all introduce ourselves? My name's Kaylee.
My name's Nehal.
I'm Lily.
I'm Alyssa.
And I'm Ria.
Okay, perfect. We're all here to discuss our procedure for consideration of cultural need, especially for our renal patients, and when a patient is on dialysis awaiting a transplant, how we're able to assess their cultural needs as well as the living donor, and ensuring that we're providing the best care we can for our patients during this time. So a theory that I think addresses cultural need that we should discuss is Lineger's theory. So according to the Nursing Theories and Nursing Practice textbook, for Lineger's theory, this suggests that nursing judgment, decision, and action should be guided by patient's culture, and we should focus on preservation and maintenance, accommodation and negotiation, as well as restructuring to provide appropriate, beneficial, and meaningful care to our patients. So this really stresses the importance of a patient's cultural need and how we're able to integrate that into proper care. So for a patient that's on dialysis while awaiting a transplant, there's a very high burden of need for what they need done. There's a lot of cares provided to manage their health. And it's very important that they're able to adhere to their medical recommendations and medicine regimen, as well as their dialysis scheduled times. So for the preservation and maintenance, when considering someone's culture, ensuring that they're able to adhere to what we're saying and that they're able to follow what is needed. This includes being able to go to appointments for hemodialysis or being able to perform peritoneal dialysis at home safely. If they are able to do it at home, making sure that it's done sterilely and educating that they're able to do it and assessing that they can perform this properly and that they know signs and symptoms of infection. For the patient, they need to follow the scheduled time for their dialysis, and because their body is no longer able to filter, their kidneys are not working properly. That's why they're on dialysis. They also may have other comorbidities that need to be considered. And so for the preservation and maintenance, we want to maintain their health and consider all the care that they need. So moving into their accommodation and negotiation, with the heavy burden of care in end-stage renal disease, it may be necessary to negotiate what the patient is able to do, especially considering what's important to their culture or what is most important to their life. So if they are still working, and ensuring that whatever our schedule looks like, they're able to either have the time off work, or maybe they're able to work from home and they can perform peritoneal dialysis at home. Ensuring that they're able to follow their appointment times and have reliable transportation to be there, that they have the support that they need, and whatever is most important in their life, that they're able to maintain this while on dialysis, because it is a very heavy burden of care. And then for the restructuring, we may need to adjust what their schedule looks like, or what cares we provide, and so that it fits their lifestyle. And if this goes both ways, they will need dialysis. There's a certain need of how often they'll need dialysis. So we can't just say once a week is good enough. And like, come in on Monday, we'll see you next Monday. But restructuring how we can provide everything that they need, whether it's hemodialysis or peritoneal dialysis, ensuring that they have proper transportation, that they have social support, and that they can follow their medicine regimen properly.
Okay. Thank you, Kaylee, for that. So I
I'm just gonna go on to the next and discuss, the specific details that we do of an assessment based on Lininger's model. So to begin, how do we assess a patient based on this theory? So you would focus on culture, care, diversity, and the universality. Sorry if I pronounce this wrong, but it's important to take a holistic approach for the patient's cultural beliefs and values. Who would conduct the assessment? So the assessment would be conducted by team members composing of the nursing staff, APN, transplant coordinators, and people part of the organ transplant team. So during this assessment, would it be more important to be face-to-face, or can you do it online or through the phone? So it is recommended to do it face-to-face. I think it's best if we ask our patients, what are their beliefs and their values, to see, their body language and how important this is to them when asking. You don't get the same experience on the phone, and it gives off better communication, better trust, and better rapport building. And if there's any circumstance that they can't be face to face, then obviously over the phone is fine, but it is better to be in person. So what kind of questions would be better to ask when doing this assessment? It is better to ask open-ended questions, and sometimes you can ask closed-ended, but it's more important to ask open-ended questions because it allows patients to freely express their cultural beliefs, values, and preferences without feeling restricted or ashamed, embarrassed to let any information out. Asking closed-ended questions can make a patient feel like they can't say much or they're limited. How long does this assessment take? So it varies, but the duration can be around 30 minutes, but it all depends on a patient's cultural background and how in-depth it is in the questions throughout the assessment. What questions? Oh, so some of the questions that would be asked during this assessment can be asked multiple times throughout a patient's journey. It should be conducted in multiple points throughout the patient's journey, including during initial admission, pre-transplant evaluations, post-transplant follow-ups, and whenever significant changes occur in the patient's condition or cultural context. This allows for ongoing evaluation of cultural needs and preferences and ensures that care remains responsive and culturally congruent over time. So yeah, by conducting these assessments, as stated by Lininger's theory in the book, healthcare providers can gain valuable insights into the cultural dimensions of patient care, tailor interventions accordingly, and promote cultural competent healthcare delivery.
Great. Good job, Celia and Alyssa. I think that you both did a wonderful job explaining Lininger's theory. And also, I think that I would expect to see some better patient outcomes through applying this theory by doing things like Alyssa suggested, asking open-ended questions, taking the 30 minutes or so to sit down and have an in-depth conversation with these patients. And I think that it would also be important to do these things to build more rapport for these patients and just develop a better and healthier relationship with them so that they can feel trusting with the medical staff. So I would hope that the patient feels a sense of comfort and trust with the staff members involved in their care. And not only would we be using the medicinal side of care, like using medications and whatnot, and going through all of the treatment for the transplant, but we would also be incorporating holistic aspects into the care, such as prayer, meditation, essential oils, music, etc., whatever it is that the specific patient wants in their plan of care. So I think that this would really help us treat and care for a patient that is undergoing transplant-related care.
All right, thank you, Nehal, for that explanation. So I'm going to go discuss another theory that we have, which is the Purnell's model of cultural competence. And this was just developed to provide a framework or outline to classify and arrange different elements that may have an effect on individuals' care. So for this, we want to assess both the transplant family or the transplant patient's cultural beliefs and also the recipients, which comes down to three theories. So basically, with cultural competence, we want to be aware, we want cultural awareness, which is basically kind of recognizing that how our own cultural background or beliefs can be affecting our beliefs of what the patient needs or wants. So it's a very diverse world that we live in, and usually with transplant patients, they could have donors from any type. So recognizing our perceptions as well as both the families and patients is very important. And this goes along with having that cultural knowledge of like understanding what their beliefs and needs are, which can only come through active listening and learning to see what they want instead of putting our own biases on their needs as well. So this goes beyond like historical, social, economic, and political factors, which can have a they can kind of shape our cultural knowledge. And of course, the last one is having cultural sensitivity, which is kind of recognizing those differences and not having those personal attitudes to have those cultural backgrounds towards those cultural backgrounds, so recognizing what that is. And this goes on an individual level and a organizational level. So in the individual level, we talked about having healthcare workers address that we need to be aware and sensitive to different cultures, but on the organizational level, it would be having those resources in place just to see what we can cater to diverse cultures, such as having translators or any type of interpretation system, having different type of options available for beliefs, and then having a different type of dietary and stuff involved. So that's being catering toward different needs as well. Yeah, thank you.
So just to add on to what Ria just discussed, Purnell's 2005 model provides a comprehensive approach to understanding and incorporating cultural competence into healthcare. And obviously, from our perspective, we're focusing more on nursing, but the model has 12 domains, so it's pretty hefty, but it incorporates things such as heritage, communication, family roles and organization, workforce issues, biocultural ecology, high-risk behaviors, nutrition, pregnancy/childbearing practices, death rituals, spirituality, healthcare practices, and healthcare providers' cultural competence. So depending on the situation that is at hand, the healthcare worker can apply these domains. Hopefully, I mean, I don't think all of them will necessarily always apply, such as our case currently, like pregnancy and childbearing practices would not be relevant. But we would still like to consider as many of the 12 as possible when having these open and honest discussions with the patient. And then we would just try to figure out what aspects are most important to them, and also including their loved ones in on the decision, because family is a huge part of care as well.
Awesome. Thank you, Ria and Nehal, for bringing up Purnell's theory. And I really like, Ria, the three concepts that you took out of the theory of like active listening, engagement, and empathy. And I'm just like a big fan of this theory and think it will be great to implement into these situations of transplant patients. And when it comes to like why we would want or need to implement this model, I think it's really important for organizations to implement it because it By doing so, we can achieve the cultural competent care that we're aiming for. And when cultural competence is met, that means that healthcare providers can demonstrate awareness regarding not just regarding their own personal beliefs and values, but then going outside of that, in addition, they also can recognize and understand the awareness of the patient's multicultural diversity. So in doing that, they can be aware of their own beliefs and values, but then also the patients, and they can also see if they interact or may cause like biases in any ways. And so from this foundation, the health professional is able to consider the needs that stem from the patient's culture while providing the care. And this would allow caregivers within the healthcare setting to assess, diagnose, plan, and implement, as well as evaluate a plan of care that is culturally competent for the patient. And this would help improve quality care that in the patients that we care for and make them, I think, just kind of what Nehal discussed earlier, better outcomes and more trust and more rapport within the healthcare team. So how would we implement this? And I would be the next question. So the Purnell model could be implemented by an organization through developing a systemic and comprehensive formatted assessment tool that would be led by the 12 domains that Nehal discussed of the model in order to assess the important cultural variables to each individual patient, including their values, beliefs, lifestyles, and practices. And since the 12 domains are very extensive, it needs to be recognized that healthcare professionals may not be able to comprehensively assess the patient regarding all 12 domains in one sitting or one encounter. And because of this, I believe that the Purnell model should be within like our electronic health record, and it should be an assessment tool that is always accessible to all relevant care team members so that we can continue to add to it during repeated encounters. And we can also, each individual healthcare team member can also evaluate existing information. And then from this information that's gathered relating to the diverse patient's cultural beliefs, values, and whatnot, we can plan strategies and individualize our interactions and interventions with them. And regarding specific like transplant patients in our case, you would want to assess both the cultural beliefs, values, and needs of both the recipient and the donor when a donor is identified that specifically relate to this experience of a pending kidney transplant, even also during dialysis, because as we have discussed, this is a very trying time. So it's really important to ask what their expectations are relating to this process of being on dialysis, awaiting a transplant, or being a donor. And if they have any specific needs or wants, and this could be something like having a religious leader present during any time of this process to pray with them or do any type of specific rituals with them, especially maybe before the surgery. Asking questions such as, do the recipient and donor want to meet and visit with each other before the transplant takes place, especially if it's a known donor? And then who would it mean the most for them to be visited by once they awake from surgery? And I know that we're discussing pre-transplant patients awaiting this, but I think it's really good in this pre-transplant time to evaluate these expectations so then we can better implement them ahead of time into the plan of care. And out of the 12 specific domains, I believe that we should focus on communication, nutrition, family roles and organization, spirituality and heritage, and then healthcare and medical practices when preparing patients for transplants and also when just caring for them in this time of dialysis and awaiting transplants.
Thank you, Lily. I really appreciate all of the information that you had to share within that model. So based on what you kind of discussed, I would anticipate practitioners of all levels, not just nurses, but advanced practice providers, MDs, members of PT, OT, whatever it is, to make cultural considerations when caring for patients. And like you mentioned, having it included as part of like the electronic health record, and then it could also be included as part of like the morning rounds, like when a nurse first checks in or when the medical team is rounding on the patient. It could be something that is brought up and discussed and probably written like on a whiteboard. I think that would be very helpful, just so that whoever comes in and out of the room is aware of those considerations that the patient wants to be made. So it can be as simple as like, do you have any cultural considerations that you would like for us to make, and kind of having it be more of an open-ended question. And then we can create a comfortable healing space for the patient and for the family members involved in the care as well. And this would also allow them to feel trusting of the healthcare team. So overall, I think that I really enjoyed learning about both of the models, but I think that Purnell's models stood out most to me. I think that I liked that it had so many different domains that were all super different from each other, but also kind of had the same underlying concept. And I think it'd be really interesting to see how they differ from patient to patient, because each patient definitely comes from a different background, different cultural beliefs, religious beliefs, whatever it is. So I think that it is very interesting, and I look forward to having it be applied more to future patient scenarios.
Thank you, Nihal, for sharing. I really enjoyed Leininger's theory on how we can accommodate when considering cultural need, or what's most important to the patient. How can we restructure and offer accommodation and negotiation so that both can be done. We can provide cares, and it can align with them continuing to have what's most important to them, the priority in their life. And I think there's great things about Purnell's model as well, but I enjoyed Leininger's theory just a little more.
Yes, I also liked Leininger's theory as well, because I just think it's important to always include what a patient wants or believes, because it can help them adhere, well, it can help them be compliant to, you know, their recovery, knowing that they feel so included with their religion and culture and everything. And it's just important, as all healthcare professionals, to include that theory throughout their care and for future generations as well. It just, again, we're trying to gain trust from our patients so they can trust coming to the hospital and just know that they're safe and understood, my bad, in our care. So yeah.
Awesome. I think like the biggest takeaway from this conversation that we've had today, I've just really enjoyed it, because I see the overall benefit that culturally competent care can bring forth, in the sense that it allows patients to better co-participate in their cares. And I know that's really important to us as healthcare providers, that we want to make decisions with our patients, not for them, and involve them in the care as much as possible. And so by being a culturally competent healthcare worker, I can better understand the patient and their cultural values, beliefs, and practices, and work alongside of them to assess, plan, and implement the care, and then make these decisions together. So I just think I've really enjoyed like recognizing the fruits that culture competent care can bring forth.
Thank you, Lily. I also enjoyed that, as well as I enjoyed Purnell's model, which provided a basic framework for creating cultural competence across the organizational level, because I know it's very hard to address every single need based on the patient-specific needs. So having that framework is very important for all healthcare organizations to address if we want to provide care that is not only culture competent, but it goes beyond just providing basic healthcare to patients. So thank you everyone for this meeting, and I hope we addressed all the necessary care that we needed for this patient or these patients. Thank you.
Thank you, guys. Bye.